Good afternoon, everyone. I would like to welcome you all to the 24th ECHO session, tele-ECHO session for management of HIV and TB. Today, we are privileged to be joined by one of our infectious disease specialists from CIDRZ, who closely work with the ID team here at UTH in the management of various complicated cases. And we will be talking about TB meningitis. TB meningitis, as you know, is one of the commonest and yet eludes the majority of us. And to help us discuss this topic, we are going to have Dr. Michael Herce. Dr. Michael Herce, please. It's everyone.
Good afternoon, everyone. Thank you for having me.
All right, thank you very much. I can see that we have been joined by a number of facilities and individuals, which I think at this point would be too numerous to mention. And before we go into today's discussion, I would like to just give a short recap of what we discussed last week. If you remember, we talked about viral load champions and people who will be assisting us in ensuring that routine viral load is undertaken. So we discussed the importance of routine viral load and that patients who have been on ART for 6 months district level and provincial level. We seem to be having a little bit of network issues. I hope that it will be able to pick up as we go on. So without much ado, we are going to start with a case that we have, and it shall be presented from the hub. So apparently it says that Dr. Herce, you're presenting the case. Okay, I will assist you and then we shall discuss the case. So the case that we are discussing today is that of a 35-year-old man who presented with increasing headache and fever for 3 weeks. He was seen at a health center 4 weeks earlier for a mild cough, malaise, and the chest x-ray was done, which was found to be normal. These symptoms were recently accompanied by progressive apathy, drowsiness. He was responsive and able to swallow. He has lost 10 kgs over this time and is HIV positive and was started on TLD 12 weeks earlier to presentation for advanced HIV and a low CD4 of 67 cells per mil. His past medical history was significant for HIV, of which he was started on TLD, as said earlier. The social history, he works as a minibus driver and stays in Kanyama. On physical exam, his vitals, the temperature was 38.3 degrees Celsius. The blood pressure, pulse, respiratory rates were all normal, and these saturations on room air were 92%. Examination of the head, ear, nose, and throat. There was no evidence of trauma. There was several 1 centimeter, slightly tender bilateral posterior cervical lymphadenopathy. CNS exam, he was responding to verbal stimuli and simple commands in Nyanja. He had a disconjugate gaze with deviation of the left eye laterally. The reflexes were brisky on the left and some weakness on the left arm and leg. He was moving all extremities with 5/5 strength on the right side and 4/5 strength on the left upper extremities and left lower extremities. Some tests were done and these results were as follows. The full blood count, the HB was 12.0 grams per deciliter, The white cells were reduced at 2.7 times 10 to the power 9 cells per mil. Biochemistries were normal. Malaria RDT was negative, and HIV 1 and 2 antibody was positive to HIV 1. So the question is, what diagnostic test or procedure should be performed next? So we are to give it a go. What diagnostic procedure should be performed next? So we can use the poll, which has been launched, to participate. Are we able to see the poll? I can't see anyone voting yet. So the question is, what diagnostic procedure or test should be performed next? Should we repeat the case? So a 35-year-old man who presented with increasing headache and fever for 3 weeks. He was seen at a health center 4 weeks earlier for a cough, malaise, and a normal chest x-ray. Recently, he was accompanied by progressive apathy, drowsiness, but he was responsive and able to swallow. He has lost 10 kgs over the last 4 weeks. Is HIV positive and was started on TLD. CD4 count was low at 67. Full blood count was significant for a low white cell, and RDT was negative. Okay, we'll click on Chipata District Hospital. Would you give it a go? Are you able to see the... Sorry? 8. Okay. All right, thank you very much. So Dr. Hicks, any comments?
Yeah, so A is not unreasonable in settings that have access to CT or MRI brain, and in a setting where you could obtain that quickly. However, in most of our peripheral hospitals, at primary health center, community hospital, and district hospital levels, those may not be available. So the best answer is actually D, lumbar puncture. I think that requires a high degree of clinical suspicion. The patient is presenting clinically at a meningoencephalitis, which is concerning because it's in an immunocompromised host, which we know has a low CD4, and there's recent ART initiation and the possibility of some CNS OI or CNS OI and iris. So if the patient had more of a dense hemiplegia or a very singular focal neurologic finding, and you were worried about a space-occupying lesion in the CNS or uncal herniation, then A may be the best answer. But in this case, in the vast majority of situations, it's going to be obtain a lumbar puncture.
All right, thank you very much. So we move on with the case. So additional studies were done. The chest CT showed diffuse patches, small infiltrates. Then cryptococcal antigen test on serum was negative. The lumbar puncture results were done. Opening pressure was 35 centimeters of water. The white cell count was raised at 225, of which 70% were lymphocytes. The protein was also raised at 2 grams per liter. Glucose was 2.2 millimoles per liter. Gram stain was negative. FP smear was negative, and Gene Expert was negative for TB. The second question, we would like people to give it a go, and if we could actually vote through the poll, that will even be better. Which of the following diagnoses is most likely? Which of the following diagnoses is most likely? So looking at the results that we were given. Can we give it a go? We've got under a minute to give it a go. Through the poll, we can poll there, and then we are going to discuss later. Kindly note that you can guess. It's allowed at this point to guess because we haven't discussed the case. Okay, we're having some feedback. Somebody's microphone is on. Choma General, are we polling? Are we going to poll or not? We haven't seen anybody polling. Choma General, would you like to share with us what your thoughts are? Lundazi District Hospital. Matero first level. Are we being heard? I'm now worried. Are we being heard? Mazabuka.
Yes.
Are you able to see the poll? Mazabuka, are you able to see the poll?
Yes.
But we can't see you polling. Okay, due to time, we'll end the poll. Dr. Herce.
Sure. So we heard cryptococcal meningitis mentioned, which is, without the laboratory data, would be high on our list of HIV-infected patient with advanced immunosuppression coming in with a picture of meningoencephalitis, right? Neurologic findings on exam, altered mental status. However, we know from the test results we give you that there's a cryptococcal antigen done on blood that's negative. So does that make cryptococcal meningitis more or less likely? Less likely, right? We also know that we have the results of a malaria rapid test, which, although that doesn't in all cases absolutely rule out cerebral malaria, it also makes cerebral malaria much less likely. And then going through the remaining diagnoses, we have TB meningitis, disseminated histoplasmosis, and schistosoma hematobium. So we do see endemic histoplasmosis in our setting, along with other endemic dimorphic fungal infections. But classically, those present as a systemic illness, characterized with histoplasmosis as either skin lesions, splenomegaly, wasting, but not usually with neurologic findings suggestive of a meningitis. So we think that's less likely. And then schistosoma hematobium doesn't often cause a meningitis-like picture. We can see things like Katayama fever. We can sometimes see in disseminated cases involvement of the spinal cord and a transverse myelitis, but a
Okay, sorry about that. I think we seem to have been off air. So I think, Dr. Herce,
Yeah, of course. So we were just going through the options on the questions and returning to, and we had decided that we could rule out reasonably cryptococcal meningitis because of a negative serum cryptococcal antigen test. We could rule out cerebral malaria because of a negative malaria RDT, and that histoplasmosis and schistosomia seemed compatible with the TB meningitis. We purposely put in a negative gram stain on CSF, a negative AFB, and a negative expert to try to throw some complications into the case. But we may see negative smear on CSF in cases of TB meningitis in 50% or more of cases, especially if the amount of CSF is limited, and we often see a negative expert. So based on the patient's presentation with a cranial nerve deficit, we heard that they have a lateral gaze of their vision, the changes in their mental status, evidence of a hemiparesis, and these CSF findings, the best answer is TB meningitis, which is the focus of our case discussion today.
So we'll now go into the didactic, which is TB meningitis. So Dr. Herce, no need for further introduction.
Yeah.
You can please go ahead.
So today we'll review TB meningitis, and I guess given the format, it'd probably be easiest to hold our discussion to the end, but I look forward to your questions and comments. So our learning objectives today, and we're all learning, myself included, is that we will describe the presentation and evaluation of patients with symptoms that are suggestive of TB meningitis.
Sorry, just 1 minute. It's not. Sorry about that.
Want me to work on this one? Yeah. Yeah. Great. All right. Okay. I think we're not. Okay, there we are. Yep. So our learning objectives are to describe the presentation and evaluation of patients with symptoms suggestive of TB meningitis, to discuss the appropriate management of patients with TB meningitis, and to explain the role of further referral. And by the end of this presentation, I hope we're all good at sniffing out TB meningitis. So the picture here is from Tanzania and an organization called APOPO, which trains African pouch rats to smell TB in sputum. So it doesn't perform as well as expert, but the animal over time and exposure to sputum with TB and getting treats for picking out TB in the sputum gets really good at finding TB with its nose. So I want everyone who's on this call to get good at finding TB meningitis with your nose and with your brain, okay? Because it requires clinical suspicion. Oh, there it goes. Yeah, something. So why is this important? Well, it's important because TB meningitis is a really fatal disease. So reports from the region show that the case fatality rate is between 15 to 40%. So if we had 100 patients who come to the hospital with TB meningitis, we worry that as many as 40 could die without proper treatment. And we often see the symptoms accelerate and patients deteriorate within a matter of a month or two, sometimes less, especially in our setting where we see a lot of HIV and advanced immunosuppression. So we need to be able to recognize TB meningitis early, start treatment early, so we can save lives together. So for me to understand any disease, I need to think about how it develops. And so TB meningitis generally follows from TB entering into the lungs, disseminating through the lymphatics into the bloodstream, and then seeding the central nervous system. So that we see in disseminated tuberculosis or in transient tuberculemia in patients who have an underlying immunosuppressive condition, and in children who we know are at increased risk for TB who have a progressive primary infection. And what happens is the mycobacteria seed the brain through the blood, they seed the meninges and nearby bone, and they form small little microabscesses or tubercles. And then by bad luck or progression of the tubercles, they rupture, releasing tubercular protein and the mycobacterium into the space between the brain and the lining of the brain, the meninges, into what's known as the subarachnoid space, which then triggers a cascade of events that cause inflammation and some of the more characteristic symptoms of TB meningitis. And this picture on your screen on the bottom right-hand corner with the white arrow just shows a small tubercle that's right at the interface of the meninges that could be a culprit for progression to TB meningitis. So the picture on your right is a cross-section of brain tissue from the outermost area, from your scalp through the skull, down towards the cerebral cortex, the brain tissue. And you see this subarachnoid space underneath the arachnoid mater and the pia mater. And that is the space where we see the most inflammation and involvement in TB meningitis. And it's important because that space is the space through which vessels and the cranial nerves pass. So if you could think of the inflammation of TB meningitis affecting that space, it will also affect anything that runs through it. And so we end up seeing symptoms of a cranial nerve palsy, like in our case, where cranial nerve 6 is dysfunctional and there's a lateral gaze on one side because that nerve is inflamed and irritated by the ongoing inflammation caused by tuberculosis in the subarachnoid space. We also see inflammation and damage to the blood vessels coursing through that area, which can lead to a thrombosis or an aneurysm or infarction. So you can see a patient that presents almost like a stroke case, as in our patient who had a left-sided weak hemiparesis. His neurologic exam was not intact. And in very advanced cases, including in cases in children, we see hydrocephalus, where the choroid gets blocked, the tissues that absorb the cerebral spinal fluid get blocked through inflammatory tissues, protein, and exudate, and they can no longer resorb CSF, causing dilatation of the ventricles and hydrocephalus. So, we have our next polling question. Regarding the presentation of TB meningitis, the following is true, except for one. One of the four is false. So A, the presentation is typical for TB meningitis in all patients. B, there is a 2 to 3 week prodromal fever stage. C, the patient may present with neck stiffness Or D, the patient may present paralyzed. Please pick the best answer.
Mr. Makando, the poll. Okay.
Ah.
Okay, so the poll is in progress. We can choose our answer. Makando is off. I can't look.
Excellent.
Try from there. Still. Okay, so we shall accept for people to just say out the answers as they think. So Maramba, if you can give it a shot, since we're having challenges with the poll system. Maramba.
Hey. Oh, they have a problem.
But I already submitted. Submitted.
Okay, great. Thank you. Kapata Clinic, Kapata Urban Health Center. Would you like to give it a shot?
Yes, A.
Okay, the poll is now on. I think we can now give our answers through the poll.
That was the old one. Yeah. This one's the old. Yeah.
Are we able to do that? Kapata?
No, through.
We already submitted.
Oh, you've already submitted. All right, thank you.
Okay. Great.
Yeah.
So 92% of you selected the right answer. So the right answer is A. So I see that there are many good test takers in medical school and nursing school. So whenever you see all, that's often a flag that life is not that clear cut. So this is the case here. So the presentation can vary depending on the patient and the stage of disease, and we'll go over that now. So TB meningitis is really a subacute febrile illness, and by subacute we mean that it usually takes more than several days to a week to sort of develop the full constellation of symptoms. And classically, patients present with 3 phases of symptoms and signs. So the first stage is called the prodromal stage, and that usually happens over the first 2 to 3 weeks. So that's characterized by feeling sluggish, having headache, a fever that may not be a very high fever. It may be hovering in 37.9, 38.5, and then sometimes personality change. The patient's not making sense. Their words may be garbled. They could be getting confused. And then slowly over the ensuing next few weeks, the next phase progresses, and that's the meningitic phase. And as the name implies, it means neck pain, meningismus. And then usually worsening headaches, nausea, vomiting, confusion, and then cranial nerve findings. So on neurologic exam, you would see abnormalities classically of the cranial nerves that have the longest path to their final destination. Those typically involve cranial nerves 3, 4, and 6 that control ocular movement. But you may see other involvement or even a facial palsy. Finally, in sort of the later stages, of the disease, after 4 to 5 weeks, a patient with advanced TB meningitis would present in what's called the paralytic phase. So they may be in coma or have a seizure, and I think many of us have seen patients present with the paralytic phase on the inpatient hospital services. But that being the case, the patients don't often follow the textbooks. So depending on the age of the patient, whether they're a child or an adult, how immunocompromised they are, and their underlying immune defenses, and the virulence of the TB meningitis or the mycobacterial strain, presentation may be variable. So it could present just like a usual bacterial meningitis, like strep pneumo or Neisseria meningitidis, or it could be more slow and progressive, and really the symptoms you see most are like an encephalitis, confusion, and personality change. So this makes it hard to diagnose TB meningitis with clinical suspicion alone. So in addition to the symptoms, we have 3 stages of disease that have been used mostly in clinical research studies to characterize the severity of TB meningitis at enrollment in studies, and it has some clinical utility. And they follow 3 stages, 1, 2, and 3, that follow the same 3 phases that we described earlier. So stage 1 is really no focal neurologic signs. The patient does not have any abnormalities on the neurologic exam, and they are talking and cooperating with you as would any patient with an intact mental status. The second stage is slightly more progressive and is characterized by neurologic findings that include cranial nerve palsy. So some of the cranial nerve abnormalities on neurologic exam that I mentioned before. And in the last stage, stage 3, this is the stage of advanced illness where the neurologic exam may reveal multiple cranial nerve abnormalities or a hemiplegia where the patient cannot move limbs on the left or the right, as well as dense encephalitis characterized by a coma or seizures. How do we diagnose TB meningitis? It's difficult. It requires a high index of suspicion, and usually the tools that we have at the bedside aren't enough. So sometimes patients will have CNS findings on their exam that will be helpful, but often those are missing. Perhaps the best tool we could have would be doing a dilated retinal exam and fundoscopy. And the picture on the right shows a fundoscopic examination, and you can see the optic disc and optic nerve sort of on the left side, and then these small punctate white-yellow circles that are over on the medial portion and the superior portion of your field. And those are tuberculomas. They're small tuberculomas that have involved the choroid. And so if you see that on fundoscopy in a patient with compatible signs and symptoms, that is a bedside maneuver that you could do with an ophthalmoscope that would be suggestive of TB meningitis. And that might be the best bedside tool. Other easily available diagnostic tests like a chest x-ray are not very helpful. They're normal half the time.
Yeah. Okay. So the second poll question is, which of the following statement is false? A lumbar puncture is essential in diagnosing TBM. B, a large volume, 10 to 15 mils, will increase the yield on gene expert. C, a negative smear, culture, and expert rules out TBM. D, start empirical treatment when you suspect TBM. So the poll is launched. We can give it a go. You launch from here. Still logged out, I think. No. So what we do is that, so if you project later on, we can just go and then we'll come and go through again. Okay, yeah, we'll proceed. Okay, so we'll come and discuss the options later on. We can proceed.
So how do you make a diagnosis of TBM if your bedside exam is not helpful? in all cases. Really, we need to rely on a lumbar puncture. And so lumbar puncture is the modality by which we make a diagnosis. And we look for some clues on CSF analysis. So this means we have to have good laboratory services and good communication with our colleagues in the laboratory. So the first is, what do you look on the cell count? So classically, you see elevation of the number of cells per microliter over what is normal, less than 5, to 100 to 500. Which is not as high as you may see in a fulminant bacterial meningitis, like from Streptococcus pneumoniae, but it's still elevated. And the key is that we see mostly lymphocytes or monocytes as opposed to neutrophils. That said, you can see neutrophils early in the course of TB meningitis, but by the time the patient presents with stage 2 or stage 3 findings, it should be a lymphocytic predominance. We also see high protein levels. It's not uncommon to see protein as high as 2 grams per deciliter or higher. And then the glucose is mildly decreased, less than 45 milligrams per deciliter. It also behooves us to get a large volume lumbar puncture with at least 10 milliliters of CSF. And why is that? Well, if you have access to culture, additional CSF for TB culture improves the yield, as does having enough CSF to do quality smear microscopy. If you have access to a centrifuge where we can spin down the CSF and resuspend the pellet for smear, that improves the diagnostic yield of smear even more. And then we would be able to use even a few milliliters, less than 2, to do gene expert testing. So getting sufficient CSF so that we can do all these studies helps us make a diagnosis. But there's a couple of important things to bear in mind. One, in studies, even if you get good sample for smear and culture, we are only able to see TB meningitis about 70 to 75% of the time. So even if the culture and the smear is negative, it doesn't rule out TB meningitis. The same goes for Gene Expert. So Gene Expert in pooled studies, looking across thousands of patients, is about 80% sensitive on CSF for TB meningitis. So if we see negative tests, but the patient, we're concerned, has a presentation compatible with TB meningitis, they have advanced immunosuppression, they had a subacute febrile illness characterized by cranial nerve deficits, they may have had a TB in the past or a TB contact, those are patients that we don't want to delay empiric therapy. We don't want to delay treatment because treatment can be life-saving. And if I leave you with anything today, that's probably the most important message I have. We have new tools that are emerging that are exciting, such as Expert Ultra, which is the next generation of Gene Expert, but we don't yet have that scaled widely in Zambia. And the sensitivity with Expert Ultra can approach over 90%, which is encouraging. So that's something we're looking forward to in the years ahead. If we're at the University Teaching Hospital or another facility with access to MRI Brain, this can be a useful adjunct if the CSF studies are unrevealing. So classically in an MRI, you see of the brain in a patient with TBM, we see enhancement here of the basilar meninges. So this is a contrasted study with IV gadolinium, and you can see that this area around the pons is enhancing, which is sort of a classic distribution of TB meningitis. This is where that arachnoid which vessels by TB meningitis. Oh, go ahead. It's important to generate Is that better? Is that better? Is that better? Is that better? Oh, is that better? Is that better? Can colleagues hear us?
Can we be heard?
Is that okay? Yeah, great. So in addition to TB meningitis, other clinical diagnoses that can present as a meningoencephalitis that is subacute or chronic in duration include the following. So one is cryptococcal meningitis, which is highly prevalent in our setting, especially among individuals with HIV and a CD4 count less than 100. Disseminated histoplasmosis, a little bit less likely, but sometimes can present similarly, especially if the patient has had chronic wasting. Then perimeningeal infection. So this includes brain abscesses and spinal abscess. So what often happens is, although those infections don't penetrate into the CSF, they cause irritation of the meninges and can cause an increase in the number of white blood cells in the CSF and a lymphocytic predominance on the differential. And then other conditions not to be missed include herpes simplex virus 1 or 2, so viral meningoencephalitis, but often we see mostly encephalitic syndrome and not necessarily other constitutional symptoms or focal neurologic deficits. A partially treated bacterial meningitis, so if a patient had strep pneumoniae or Neisseria meningitis and only got 2 or 3 days of antimicrobial therapy and then had interruption of therapy and recrudescence of symptoms, a repeat lumbar puncture could show a mixed picture of elevated protein, decreased glucose, and leukorrhea that's suggestive of bacterial meningitis. And then the last two are neurosyphilis, which we see in our setting and can often cause the same sort of vasculitic phenomenon and stroke-like presentations, and then finally cancer, most especially lymphoma. How do we manage TB meningitis? Well, we don't have a lot of great clinical trial data to guide us, but we know that we use essentially the same medicines as we do in pulmonary TB, and we use the same approach. But we have to be aware of a few caveats. So the first is that just like we see iris in patients with HIV, we can actually in TB meningitis see a paradoxical worsening. We start them on TB medications, and up to a third of them will get worse within about a week of starting treatment before they get better. And this is just due to the sort of extensive burden of disease and the inflammation that we see. And in this picture on the right, you see some of this arachnoiditis. So this white fibrous matter is encasing the basal portion of the brain. And this from autopsy and TB meningitis. But this level of inflammation often is what causes these cranial nerve deficits and decreased mental status. The drugs we use, then we can even extend our treatment longer. So the continuation phase is 16 months and the full duration of therapy is a total of 18 months. And this is a slide I borrowed from the CDC and the International, or the Infectious Disease Society of America, which was endorsed by WHO. And this is sort of how we as clinicians should think about whether or not to initiate anti-TB therapy empirically. And it's a complex decision. And often in cases of TB meningitis, time is of the essence. So we evaluate a number of factors based on the patient, lab data, our clinical suspicion, and the public health importance of the patient's condition. And we make a decision about whether we treat empirically, we sit on the fence and do nothing, or we withhold treatment. And I just wanted to point out for the patient that we presented in the case, we see that this patient was immunocompromised, like many of our patients with HIV. He had a reasonable TB exposure risk. He's from an urban informal settlement with high TB prevalence, Kanyama, and he's exposed in his line of work to many people coming in and out in a closed space that would expose him to TB acquisition. So the patient is really at risk for TB. He's got radiographic imaging consistent with TB, and although his microbiologic studies on CSF didn't show TB, he had other findings, including elevated cell count and protein suggestive of TB. And we know that he has already severe neurologic symptoms that are concerning for life-threatening TB disease. And although the public health importance because of TB meningitis isn't as severe, we did see some abnormalities on his CAT scan suggesting he has TB in the lung. So when you think about this gentleman, all of these factors suggest we should initiate treatment and not delay. Okay? And we kind of think through this informally, but sometimes it's good to talk it out.
Okay, so our third and last question. In addition to ATT and ART for people living with HIV, what other medications are indicated for the treatment of TB meningitis? A, is it ibuprofen? B, fluconazole? C, corticosteroids, e.g. prednisolone? C, heparin?
That's going to be D.
Okay. Or D, sorry.
Yep.
We can launch
Mm-hmm.
from there. No. Okay, so I think people have already started voting.
Excellent, yeah. So we have 12 votes.
Okay, let's keep on voting.
Only after a minute.
That adding steroids if not, and so there's clear guidelines in the Zambia HIV national guidelines and the national TB guidelines that show how to dose this. So we generally do a maximum of 60 milligrams per day of prednisolone, which is what we use in most adults, and we continue that for 2 weeks. And that's to kind of decrease all that inflammation we were talking about on some of the pictures we saw of the brain on MRI, and then on the gross pathology of the pons of the brain. So we continue that for 2 weeks, and then we begin a slow taper by 10 milligrams in the daily dose each week over the next 6 weeks. So total, the patient is going to get steroids on top of their ATT for 8 weeks. It's important that we do this taper slowly so that we don't stop the steroids all at once, because if that happens, then the symptoms can come back worse. Another unique aspect of management of TB meningitis is when we start antiretroviral therapy. So we know from good studies, and we have clearly spelled out in our national guidelines, that we want to start antiretroviral therapy for patients with TB disease as soon as the TB therapy is tolerated. And we usually do that within 2 to 3 weeks, regardless of the CD4 count or the stage of illness. And we know the skull, right? So there's not a lot of space for that brain and what's inside the skull to expand. The skull is fixed. So if we start ART too early and we cause a lot of inflammation, it's going to cause pressure against a fixed space, and that's associated with increased mortality. So in TB meningitis, we do something a bit unusual. We wait for about 8 weeks before we start ART. The patient is, by then, tolerated their anti-TB therapy, they've gotten their steroids, even if the CD4 count is low, and then after 8 weeks of TB drugs and steroids, we start the ART. And this is associated with better outcomes. Finally, are the questions of referral, and this can be very challenging, especially at primary health center or district hospital. But in general, there are a couple of complications of TB meningitis that we should look out for. The other condition would be if we make a diagnosis of TB meningitis by gene expert, and we note that the Mycobacterium tuberculosis is resistant to rifampin. So then that would be a case where the patient would require second-line drugs, and they would have to be referred to a center of excellence for the management of drug-resistant TB. So this is our last didactic slide, and just really to emphasize the key points. So there's 6. And the first is that given the high case fatality, it's really important to have early recognition and a high index of suspicion so we don't miss any cases. Doing a lumbar puncture is essential to make the diagnosis. And in some cases, you can start the patient on TB therapy. And if the first LP is negative, but your suspicion is high, you can repeat it. And you can still get a positive smear, a positive culture, a positive expert, even 7 days or longer afterward. So you can always return to doing a repeat LP if necessary. A negative CSF smear culture expert does not rule out TB meningitis. We do not want to withhold TB therapy in cases of suspected TB meningitis because the treatment is life-saving, especially in cases where the clinical presentation is very compatible with TB meningitis. Effective TB meningitis treatment requires corticosteroids in addition to TB therapy, and we should delay ART treatment for 8 weeks after anti-TB therapy start in cases of TB meningitis. So these are references. So I'll turn it over to Dr. Mupeta.
All right, thank you very much, Dr. Herce. And I think what we'll do is, before we invite questions, we'll just try to revise with the 4 questions that we had for the didactic.
Okay, so we'll revise the 4 questions, and we'll start with the first 4 question regarding TB meningitis. Are we still having connection issues? Am I being heard? It's okay. Please send it. So we'll try to relaunch the pause. I must apologize that the internet today, I think, is very unkind to us, and we are failing to maneuver as smoothly as we can. But as we are trying to relaunch the poll, I will now invite questions from the audience. Any questions and clarifications? As we know that TB meningitis is quite common, but one of the most difficult diagnoses to make. And issues of when to refer is also something that I think a lot of people are finding difficult. Any questions or clarifications?
Hello? Hello?
Hello?
Yeah, this is Sons of Thunder.
Yes, sir, we can hear you loud and clear.
Okay, my question is on the vomiting. Is this more a projectile type vomiting or your typical porcelain god vomiting?
Well, I didn't catch that last part, sorry.
is this more projectile vomiting or the typical, what we refer to as bowing to the porcelain god?
Yeah. So I think it depends on the stage of clinical illness. So it varies. So I would say early on in the prodromal phase or stage 1, it's probably more just general malaise and sort of abdominal discomfort and general constitutional symptoms. By the time you get to stage 2 and 3, where there's evidence of more severe CNS involvement and the possibility of increasing intracranial pressure, especially if there's evidence of hydrocephalus, it could be more projectile vomiting compatible with increased intracranial pressure. So I think you really have to take a good history to know when symptom onset began to really kind of make that determination. I think to answer your question succinctly, it can be variable, but there may be clues in the style of vomiting that give you a hint to how long the process has been ongoing, what stage of TB meningitis you're finding.
All right, thank you very much. I think we have got a raised hand from Macha. Macha, please go ahead with your question.
I would like to find out for how long a patient on second-line TB treatment would have to be on treatment if they had TB meningitis.
That's a great question. So there's limited data on that, mostly from case series and cohort studies. I think in general, we would use an individualized treatment regimen, which would be founded really on the new WHO recommendations just from December last year. So that would end up being probably 24 months of therapy. And that would have to be 24 months of therapy based on evidence of clearance of the CSF cultures. So those cases are really cases you want to be managing at a central hospital level, ideally, where the patient can get a repeat lumbar puncture to prove sterilization of the CSF, and then we would time therapy from the date of sterilization and usually extend for 12 months past the date of sterilization, which could be a total course of treatment with second-line drugs of about 24 months. But that's a great question.
Okay, thank you very much. Earlier on, Yeta District Hospital had a question. Do you still have that question, Yeta? Yeta, can we locate them? Can't. Yeta District Hospital, do you still have a question? Okay, so there's a typed question here. Yes, Yeta, we can hear you.
We are saying it's clear.
It's clear now.
And the presentation, yes, the presentations in the TB meningitis patients, it has been elaborated. We were behind. Now from what has been said, we are now able to get one or two things.
All right, thank you very much. Thank you. So there's a question that with such a high mortality, what are the ways to prevent TB meningitis?
That's great. So I don't know, I usually like to ask more questions than answer, but maybe I'll ask the team here, what would be a good way to prevent TB meningitis?
The hub, people in the hub.
And I'll give you a hint. I think Dr. Lungu mentioned this previously.
I'm not sure, but if we screen clients every visit that they come to the clinics, then we'll prevent the primary TB, which will prevent the TB meningitis.
Okay. So we said active case finding and screening in our clinics. I think especially among people living with HIV, that's good. There's another medicine sometimes in clinic.
INH?
Good. So TB preventive therapy. So right now that's INH, and I think increasingly it's going to be combinations of shorter courses. So if we can get rid of the TB infection, right, the latent TB infection, then TB meningitis that happens over the course of immunosuppression and reactivation, those numbers will go down. So, and then the last one is early case finding for HIV. So we know that as people are more immunocompromised, particularly when they have either a primary infection or reactivation, the likelihood that they develop a mycobacteremia and dissemination goes up. So if we can start our patients from reaching them in the community when their CD4 count is 800, it will do us a lot better in reducing the risk of this, as opposed to starting our patients when they come to us late at a CD4 of 100.
Thank you very much.
Great question.
Yeah. Chilenge, your hand is up. Please go ahead with your question. Chilenge? Yes, please go ahead.
My question is on empirical treatment of TB meningitis. Let's say you have a case of a patient who comes in with symptoms of a TB meningitis, but when you do a gene expert, it turns out negative. And then after that, you start them on empirical treatment. But during the process, there is no improvement. Now, when do you discontinue treatment of TB? When you have a case where
okay, so I think that's the same question that is coming from St. Francis. So
yeah,
we can answer it at the same time.
I think that's a great question, and that's where the guidelines are a little bit more challenging, right? So in general, what you could do is try to establish an alternative diagnosis. So if you can establish an alternative diagnosis, such as cryptococcal meningitis, partially treated bacterial meningitis, some paravertebral or paraspinal or cerebral abscess, then I think you feel much more comfortable stopping the TB management, and then you should be thinking about how do you give them a preventative TB therapy course. So if they received a month of combination therapy, you could sort of consider alternate TB preventive therapies in consultation with an ID expert, which would be a short course of rifampin monotherapy for another about 3 months. But I think the challenge is remembering that there's often this paradoxical reaction. So you may see a patient get worse with TB meningitis who truly has the disease during the next 2 to 3 weeks. So you have to give the treatment course sufficient time to bridge the patient through that. And you also want to try to establish an alternative, more compelling diagnosis. So in that interval, you should be thinking about getting CNS imaging. You should be thinking about repeating a lumbar puncture, making sure you send it for a crypto antigen, and then potentially other diagnostic tests so that when you stop the TB therapy, you feel confident that you've made an alternative diagnosis. But those are really challenging cases.
Okay, thank you very much, Dr. Herce. I hope, St. Francis, your question has been adequately answered, but if not, kindly let us know. Chipata District, the question is, what is the main reason why ARTs commenced 8 weeks after starting of ATP?
Great question. So in the case of TB meningitis, the rationale behind this is, remember, and I think it's because of our audio connections, the brain is sitting in a fixed space. The skull in adults does not expand. So if there is an incredible inflammatory response caused by immune reconstitution through the good work of antiretroviral therapy, if you recover your CD4 cells, your cell-mediated immunity, you're going to cause inflammation of the meninges around the brain. And so if you do that before there's been adequate time to mop up TB infection in the brain, there's going to be a lot of inflammation that's going to try to force the brain through the foramen magnum and cause uncal herniation. And that's how patients die. If you give yourself 8 weeks of TB therapy and steroids, you get that inflammation under control. You start killing the mycobacteria in the CNS, and then when you start ART, there's not as much of a dramatic inflammatory response. So the patients will do better. And that's been borne out in large prospective trials from Southeast Asia. Great question.
Okay, so thank you very much. Are we able to launch the 4 questions again? No. Share the results. Okay, I think it's having difficulties. So we can just, I think, just go through again, just as a recap for the 4 questions. The first 4 question was regarding TB meningitis presentation. The following is true, except the presentation is typical in all patients. There is a 2 to 3 weeks prodromal fever. C, the patient may present with neck stiffness. D, the patient may be paralyzed. So we had a few who had gone for C, which is the patient may present with neck stiffness, and D, the patient may be paralyzed. Just a quick comment on the actual answers as a way of revising and summing up.
So the actual correct answer is A. So the false choice is presentation is typical in all patients. So as we saw, presentation can be highly variable. It can be a rapid onset illness, particularly in the profoundly immunocompromised, or it could be more of a chronic presentation with encephalopathy that takes place over weeks. So it'd be highly variable.
All right, so the second poll question was, which one of the following statements is false? A lumbar puncture is essential in diagnosing TBM. B, a large volume CSF of 10 to 15 mils will increase the yield on expert. C, a negative smear culture and expert rules out TBM. And D, start empirical treatment when you suspect. So we had a number of them, which is about 79% going for C, and 4% for B, and then 17% for D.
So I think the point we want to remember here is that although we need to do a lumbar puncture, we're going to miss probably 20 out of 100, if not more, cases of TB meningitis if we just rely on CSF results. So you can't just rely on that. Even if the CSF shows a smear that's negative, expert negative, culture negative, it could still be TB meningitis. So if the patient is sick, they're the right host who's immunocompromised, you want to start empirical treatment while you do further workup.
Okay, so the answer here is C.
Correct.
Yes. The last poll question was, in addition to ATT and ART for people living with HIV, what other medications are indicated for the treatment of TB meningitis? Is it A, Brufen, B, fluconazole, corticosteroids, and D, heparin? We had about 8% going for B and 92% going for C.
So the correct answer is corticosteroids, as we talked about, right? About 1 to 2 milligrams per kilogram of prednisolone, or the equivalent of dexamethasone, for 2 weeks, followed by a taper, reduces your mortality by 30%. So really, in addition to your TB treatment, helps save lives.
And the last question now is, any interaction between dolutegravir and rifampicin, coming from Maramba?
Great question. So yes, so as you all know, if a patient is on TB drugs, it's a cytochrome P450 inducer, right? In these cases, you need to do what? Right, you double the dolutegravir dose from 50 once a day to 50 twice a day, and you continue on the Truvada. Great.
Okay, so thank you very much. This has been quite an exciting topic, and it's one that is challenging for many of our clinicians. We would like to thank Dr. Michael Herce for coming to be with us for that wonderful presentation. I'd also like to thank everyone here in the hub and everyone who has joined in the network for your participation. Until next week, it's bye-bye from us.
Thank you. Yeah, that was great.
I've got a question.
Yeah.
Anyway, things are becoming clear now.